I just asked you and you don't know how to call 911. You don't know what to do in an emergency. You answered wrong about what to do if there's a fire. Hi, this is Dr. Alan Lifton from Brain-Splained. So, all right, outcome measures. Outcome measures is the scientific term that we use for what are we measuring. And outcome measures for the determination of physician quality are exceedingly problematic, and famously so. And the people who have an academic interest in this issue are plagued with measuring problems. So I just want to say one tiny little bit of information that is important, and that is that patient satisfaction, which is very important to me and which I work on very hard and I take very seriously, is a funny thing. I would say that as a general rule, most of the time, if you were able to assess patient satisfaction, it's a relatively decent metric of something. But there was a physician here, I shall call him Dr. Jones, and that is definitely not his name. There was a physician here when I got here 30 years ago, Dr. Jones, who was, probably the worst doctor in town, I think. And those of us who were his colleagues who talked about him were all concerned about his diagnostic ability and his treatment recommendations. And he was the greatest guy. He was just the greatest guy. He had the best bedside manner, and his patients loved him. All of his patients just loved him. And he was very caring and very compassionate and very incompetent. And that specific individual sticks out in my mind as being critically important because he demonstrates a flaw in that metric, because that metric is strongly influenced by parameters that may not be easily accessible to patients. Without the training, it's very difficult as a patient to make an accurate assessment in all situations about the diagnostic accuracy of a physician or about the optimal treatment. And I want to talk about this one little tidbit. Bad patient satisfaction can occasionally be an indicator of good quality of care. And that's very tricky business. Now, that's not a general overview. That's not overwhelmingly most patients that see that physician. This is just one singular episode, one singular complaint. And here they are, for me, as a general neurologist, absolutely you cannot live at home. There's no way that's safe anymore. It's way too dangerous. Your daughter is right. Your son is right. You have to go. I just asked you and you don't know how to call 911. You don't know what to do in an emergency. You answered wrong about what to do if there's a fire. You don't know where the fire extinguisher is in your home. You're not safe. Is that patient going to be, is that patient likely to be happy with me? God, no. Am I going to do it? Yes, I am. And I'm also going to be blunt about it. And it's going to be unpleasant. It sucks. And the people who, need me to put them on benzos, I need Valium, 10 milligrams, 18 times a day. I'm like, no, I'm not doing that. And the people who need opiates, I need to be on 200 micrograms patches of fentanyl on top of Dilaudid PRN. Those people are not happy. But it's nuanced. Those are simple and those are straightforward, and it's nuanced. I was in a patient room. Somebody wasn't here. I don't remember who was sick, but one of my staff was sick. Somebody called in, and I had no scribe. And so I was in a room alone, which, I don't really do because I'm XY. So I don't go into rooms alone. And I was seeing a patient for epilepsy, and we talked for a while about a new patient, talked about her seizures, and had a difficult time with her because she very much didn't want to be dealing with having medication changes, and I didn't like her medications. She's on Keppra monotherapy for seizures and is still having ongoing seizure activity with a frequency of about 2 seizures per month, all nocturnal, and I'm not happy with that, so I thought we needed more anticonvulsants, and she didn't, and she wasn't going to take them, and I kind of said, okay, well, there we go. And it was kind of the end of the visit, and then she randomly brought up her prior history of abuse and, physical abuse and sexual assault, and it was in a strange way, It was in a strange way because she was emotionally detached from it. I've had thousands of patients talk to me about those issues, and you can tell there's something happening in them. it's a hard thing to talk about. There's a way it's presented. There's a change in tone. There's a change in persona. There's, something. And that wasn't there. It was weird. And I was letting her talk because it's what I do. So I'm letting her talk and I'm listening to this story and I'm thinking, this is just wild. This doesn't even make sense. This is bizarre. And I wondered for a while if she was confabulating. And I'm like, no, this woman is really, she's not confabulating. And I was wondering about, if this was some other delusional thought process or something weird was going on. And it took me a few minutes. I mean, she got through a lot of the story. Maybe, she got through 10 minutes or so of talking about this stuff. And then I said, no, this is some weird psychopathology and I'm feeling uncomfortable. I need to terminate this. And I cut her off. I said, no, we're just going to keep you on Keppra. That's the plan. And I walked out the door, rudely, deliberately, like, I'm done here. Needless to say, she was dissatisfied with the encounter because I was rude and I didn't want to listen to her because what she was talking about was not germane to her neurological condition. It was not a part of any neurological syndrome. It was not appropriate to the clinical encounter, and I didn't like it. I made her dissatisfied because, I cut her off. I don't think that was bad care. I think that was good care. I don't think she should be doing that. Whatever it is that she was doing, I don't think she shouldn't be doing it. If you read negative reviews online about somebody, that's a tricky way, I think, to determine the physician quality. One of the things that you have to filter that complaint through is the lens of, is it possible that this person had an adverse experience that demonstrates good quality of care? And I don't know how you tell because you're hearing a biased presentation of the interaction. So anyway, I don't know. That doesn't help us figure out who's a good doctor, but I hope that's brain-splained anyway.